Hey everyone, welcome to the SMILE Project, the podcast of the School of Dentistry IMU. Thank you for joining us today. This section of the SMILE Project is called the Dental Bites. Tune into this section for bite-sized learning on the go. My name's Isaac, it's a pleasure to be hosting you today, and today for the speaker we have Dr. Naveen Chhabra, and his topic today will be the tips to accurately determine working length using the electronic apex locator.
Thank you, Isaac, for your kind introduction. Electronic apex locators are boon to endodontics. However, at times, the clinicians or the students find it difficult to estimate accurate working length during root canal treatment. Hence, through this podcast, I would like to share a few clinical tips to maximize the effectiveness while using electronic apex locators in the clinic. There are various tips which you can consider and you should always take care of during your clinical working length measurement. First of all, always carry out the preoperative checks to ensure that the electronic apex locator is functioning properly. What do I mean by that? Ensure that the batteries are full to yield the most accurate result. That means they are appropriately charged. Inspect the probe cord for cracks and exposed inner cabling. It may cause short circuiting or it may disrupt the connectivity. Thirdly, ensure that the probe is fully inserted into the canal measurement module and is not loose. Lastly, connect the lip clip or the contrary electrode and the file clip or the file holder together, and if the LCD displays stable illumination of the red bar adjacent to the apex, then your electronic apex locator is working correctly. If it doesn't show the stable reading or it fluctuates, that means there is some error in the circuit. You should get it rectified. Coming to the next part, you should always carefully select the reference point. Students should always select a reproducible reference point that does not involve moving the file under stress. On occasions, minor modification of the tooth is indicated to achieve a stable and reproducible reference point, like flattening of the cusp tip using a diamond burr. This will allow repeatable and reproducible reference point. It is very important to determine important anatomical landmarks using the electronic apex locators. Be aware that you should always perform coronal flaring of the root canal prior to obtaining the zero reading. Always use a small size file, generally a size 8 or 10 file, and advance the file towards your estimated working length. In case of larger canals, it can be bigger size file like 15 or 20 also. As you approach that length, attach the file holder to the endodontic file within the canal and advance slowly with watch winding motion until the file approaches the bottom green zone or the bottom green bar of the electronic apex locator display. This signifies the zero reading and represents the file being at the apical foramen. Next, advance the file slightly to the first red bar with small files only. Now in this case, you will be determining the patency of the apical foramen. Okay. So make sure you do not use bigger size file in this case. So always use small size file. So 8 or 10 file is appropriate. So in this case, you will just advance the file slightly to the first red bar and stop. Next, rotate the file counterclockwise until it gives a stable reading at the 0.5 reading or the middle of the green bar with an arrow mark. I am taking the reference of J. Morita apex locator root ZX for your reference because it is commonly used apex locator in our clinic. In most cases, this reading can be used to determine the position of apical constriction. So now we have three anatomical landmarks ready. Number one, we evaluated or discussed about apical foramen. Then we understood about the patency. Then we understood about the apical constriction. If the reading is not stable, consider using large size file. You have to be very careful. Canal is not flooded with excessive irrigant or excessive inflammatory exudate within the canal or the apical foramen, or there is an absence of root fractures or immature open apical foramina, perforations and resorptive defects. All these may affect the accuracy of electronic apex locator readings. Now we will discuss about the important anatomical landmarks that are simulated on electronic apex locators. Here I mean by anatomical landmarks the anatomical landmarks of apical zone of the root. These are apical foramen and apical constriction. Whenever you are using apex locator, make sure you have done the proper coronal flaring. Secondly, always use small size file, generally size 8 or 10, and advance the file towards your estimated working length that is shown on the radiograph. In cases of larger canals, you can use even bigger size file like 15 or 20 as well. As you approach that length, attach the file holder to the endodontic file within the canal and advance slowly with a watch winding motion until the file reaches the bottom green bar on electronic apex locator. This is the zero reading and represents the file being at apical foramen. Now advance the file slightly to the first red bar, but make sure you are using the small size file only. This length represents the length to which your patency file should be placed. Lastly, rotate the file counterclockwise and try to retrieve until you get the stable reading at the 0.5 reading mark in the apex locator display, which is usually middle of the green bar with an arrow mark. Here I am taking the reference of Root ZX electronic apex locator, which is commonly used by the students in our clinic. So in most cases, this 0.5 reading mark is reliable and used to determine the position of apical constriction. Now, understanding and reproducing this apical constriction after each instrument is very important, because your canal preparation as well as the filling material has to terminate at apical constriction. Simultaneously, you have to achieve adequate patency using small size file after every instrument. So until now we learned about various anatomical landmarks like apical constriction and apical foramen, and we know that our canal preparation should terminate at apical constriction. In most instances, subtracting 0.5 to 1 mm from zero reading, that is the apical foramen, will yield the satisfactory point to terminate the canal preparation. Now, when you are doing the instrumentation, as the canal geometry changes with the increased dentinal removal during the mechanical preparation, the working length will also get altered. Hence, it is very important to keep on recording the working length using electronic apex locator and getting the stable apical constriction or the termination point, so that you are not over preparing the canal and also you are not losing your working length. Simultaneously, patency should also be confirmed between each file by placing a small file, probably size 8 or size 10, just beyond the zero reading, maybe 0.5 mm beyond it. So it will eliminate any debris accumulation, or at least it will minimize the debris accumulation in the apical constriction area, so that achieving appropriate canal patency.
Okay, doctor. So until now, we've covered things like reference points and establishing apical stops, apical foramen, all the anatomical landmarks and canal preparation tips and all that. But for example, you are treating a tooth with metallic restorations. How are you going to deal with that now?
That's a very valid and good question, Isaac. So whenever we encounter a tooth which requires root canal treatment and has extensive metallic restoration, for example amalgam restoration, it is always prudent to completely remove it. Why should we remove it? Because metallic restorations will lead to the short circuiting and will not allow us to accurately determine the working length. Hence, it is always prudent to remove completely. However, in certain situations we do not have option but to retain it. So in those cases, you can always cover the file with a insulating medium such as Teflon tape, so that it doesn't come in the direct contact with the metallic restoration while calibrating the working length. Secondly, you can always coat a liner of glass ionomer around the amalgam so that metallic restoration is not in contact with file.
Okay, doctor. Thanks for that. I've got another question. Sometimes when we are doing root canal treatments, we encounter teeth with long roots and long canals, and we are unable to properly establish working length because the files are too short or some other problems. So how would we deal with a situation like this?
That's again a very good question, Isaac. So whenever you encounter the longer root canal lengths, for example maybe 25 mm length or 24 mm length or 23.5 mm length, in those cases if you have only 25 mm length file, it will be very difficult to attach the file clip as well as reach the complete working length. So in those cases, the best option is to have a bigger length file. That is the safest option. So you can opt for 31 mm file length. At times we are short of the 31 mm file. In those cases, what you need to do? You can just cut down the plastic portion of the head of the file by using some trimmer, or you can use some cutter, so that you can attach the lip clip properly over there, as well as have the stable reference point as well as the space for rubber stopper. So this is the very simple and easy tip and trick for dealing with long canals. So to conclude with this podcast, I would like to say, whenever used correctly, the electronic apex locator may expedite treatment, reduce the need of intraoperative radiographs, thereby reducing the unwanted radiation exposure to the patients, and also it results in biologically oriented chemomechanical preparation length that maximizes the likelihood of successful outcome and minimizes the post-endodontic flare-ups.
Alright, so thank you, Dr. Naveen, for sharing your very useful insight into establishing working length using the electronics apex locators. Thank you for tuning in to the Dental Bites, and we'll see you next time.
Thank you.